I welcome you all to today's webinar, Meet the Experts Oncology 2024, where we have several experts in the field of oncology to discuss and share their valuable knowledge with us. Now, for the first talk, I would like to invite Dr. Shahida Nazreen ma'am. Ma'am is consultant radiation oncologist at SKIMS Srinagar. Over to you, ma'am.
A very pleasant good evening to everyone. I'm Dr. Shahida, and my talk today is how I diagnose and manage lung cancer. Before going to the proper talk, I just want to give you the overview of the lung cancer because that will help us understanding why lung carcinoma discussion is so important. This is as per the Globocon 2020, the burden of lung cancer worldwide. As we see here, as per its incidence as well as mortality, lung carcinoma comes at the first place. So we can say that the most common malignancy diagnosed along with the mortality is the lung carcinoma. This is the worldwide distribution. And as far as India is concerned, it is second most common malignancy in men, only after the lip and oral cavity. And in women, it comes at the fourth place after breast, lip, oral cavity, and uterine cervix. As we see here, 7.8% of deaths are contributed to carcinoma lung. And the most important thing about the lung carcinoma is that most of these lung cancer cases are attributable to the smoking. So if we stop the smoking or we start the programs for awareness of smoking, we can drastically decrease the incidence of lung carcinoma. Now going to the today's talk, first I will start with the presentation of non-small cell carcinoma. It depends upon the growth where it is located. If a patient has a central growth, patient will present with cough, hemoptysis, dyspnea, wheeze, pneumonitis in the form of pain. If patient has a peripheral growth, he can have cough, dyspnea, or lung abscess. If patient has a loco-regional spread, that means the surrounding structures, mediastinum is involved, or the chest wall is involved, patient can present with hoarseness of voice, dyspnea, diaphragmatic palsy, Horner syndrome, SVC syndrome, and Pankos syndrome. And unlucky person who has metastatic disease present with the symptoms of the organ or the system which has been involved by the metastasis. This is the initial diagnostic workup. If we suspect from the clinical features that patient can have a lung malignancy or lung cancer, first we will start with the simple chest radiograph. If it is abnormal, then we need a tissue biopsy, for which, if a lesion is central, we will do a sputum cytology or bronchoscopic biopsy or transthoracic biopsy that will give us the tissue diagnosis of the lung carcinoma. But if person has a peripheral lesion, we can go image guided biopsy, thoracoscopic guided biopsy, or thoracotomy, and then the open tissue biopsy. That will give us the tissue diagnosis of the lung cancer. Other investigations tool for the staging purpose includes the imaging, which includes the CCT chest and PET-CT scan, IBUS, EUS, mediastinoscopy, MRI brain, and bone scan. First thing in imaging, we do a simple chest X-ray. Chest X-ray gives us a simply idea about the mass lesion. It won't tell us anything about the infiltration, size of the lesion, or the nodal status. So when we suspect on chest X-ray patient is having a mass lesion in the lung, we will proceed further with the further imaging procedures. Most common and the most important imaging technique in non-small cell lung carcinoma is the chest CT scan. It is more sensitive than X-rays, and it determines the position, size, shape, and extent of the tumor, and to assess whether lymph nodes are enlarged. In other words, we can say CT scan helps us in assessing the clinical stage of the disease. As we see here, this is the CT scan of a person with lung mass. We can see there is a peripheral lesion which has infiltrated the chest wall, but it has not involved the rib cage. Another imaging technique is the PET scan or PET CT scan. PET scans are not that much of help in non-small cell lung carcinoma because they don't properly tell us about the anatomic definition of the suspicious lesions. So we should always combine PET with the CT scan. So PET CT is indicated. NCCN and ESMO recommend combined PET CT for all clinically assessed stage 1 to stage 3 patients to detect mediastinal disease and distant metastasis. But here we have to be cautious. If mediastinal disease is detected on PET CT, we further need a tissue diagnosis to confirm whether it is really involved by the disease or not. Here we can see this is the PET only scan in which there is increased uptake, but we cannot say about the anatomy properly. So the PET CT is more accurate. Here we see the peripheral lesion and there is a mediastinal lymph nodes also. Another imaging modality is MRI. MRI is not routinely indicated in the non-small cell carcinoma. It is usually indicated for the screening of the spine and the brain screening. NCCN recommends brain MRI for patients initially clinically assessed as stage 2, stage 3, and optionally for stage 1B. It is not recommended for stage 1A. But at the same time, ESMO guidelines state that brain MRI might be useful in patients with stage 1, stage 2 disease considered for curative therapy, and it is indicated in all patients with stage 3 disease. Contrast enhanced MRI is preferred over CT scan because it helps in better delineation of the soft tissues. As we see here, there are multiple brain metastases in MRI of scan of this patient. Another imaging is the bone scan. Bone scans are only indicated when PET scan results are unclear. Bone scans are considered an integral part of staging patients with potentially operable non-small cell lung carcinoma. Whole body bone scans are useful in staging patients with non-small cell lung carcinoma. Patients with metastatic non-small cell lung carcinoma could be understaged due to asymptomatic bone metastasis and may not benefit from surgery to remove the primary disease. For tissue diagnosis, we can have FNA biopsy or the core biopsy. For FNA biopsy, we can do it by transtracheal FNA or transbronchial FNA during bronchoscopy or endobronchial ultrasound. And for core biopsy, most of the core biopsies are image guided, mostly the CT guided or the UHG guided. After we get the tissue from the biopsy from the tumor, first this tissue is examined under the microscope to differentiate between the various histologies like non-small cell carcinoma, small cell carcinoma, and then different types of non-small cell carcinoma. Depending on the histology, we subject this tissue for further molecular testing like EGFR, KRAS, and at the same time, we will do PDL1 testing on tumor cells. This is the mediastinal staging algorithm. If on PET CT with intrathoracic lung mass disease, patient has mediastinal lymph nodes negative on PET CT. That means patient has a clinically N0 or low probability of unforeseen N2 disease after negative PET CT. Patient will go directly for surgery, and if he is not fit for the surgery medically or having other comorbidities, he will undergo the radical radiotherapy. But if patient has a clinical N1 disease or there is clinically N0 and high probability of unforeseen N2 disease after negative PET CT, tissue confirmation through IBUS or the EUS is important. If mediastinal lymph nodes are negative, surgery or radical radiotherapy is to be done. But if patient has a mediastinal lymph nodes positive after tissue biopsy, he will undergo the multimodality treatment. Likewise, if there are mediastinal lymph nodes positive on PET CT, but there is no mass or no bulky lymph nodes, tissue confirmation through IBUS or the EUS is important. If the mediastinal lymph nodes are negative, multidisciplinary evaluation of surgical staging is important. If mediastinal lymph nodes are negative, the treatment will be surgery or radical radiotherapy. But if patient has a mediastinal lymph node positive, he will undergo the multimodality treatment. If patient has bulky lymph nodes or mass is visible along with the increased activity, there is no tissue confirmation required. So this patient will directly go for the multimodality treatment. This is the sensitivity of various investigations for mediastinal lymph nodes. Less invasive is EUS, EBUS biopsy, EBUS biopsy, but its sensitivity is 89%. VATS has a highest sensitivity of 99%. This is the AGCC 7th edition and 8th edition staging of the lung carcinoma. There is only one difference. In AGCC 7th edition, T2B was greater than 5 centimeter but less than 7 centimeter, and T3 was greater than 7 centimeter. That has changed. T3 is greater than 5 but less than 7 centimeter, and greater than 7 centimeter is T4 lesion. It has upstaged it in the AGCC 8th edition. This is the 5-year survival as per the stage of the patient. As we see from stage 1 to stage 4, 5-year survival decreases drastically. In stage 1A, 5-year overall survival is 67%, stage 2B 40%, stage 3A 25%, and stage 4 it is less than 1%. This is the advances in many. This is a paper which has come in New England Journal of Medicine in 2020, August 2020, in which they have shown that advances in management of non-small cell carcinoma has improved survival. What their results showed that the lung cancer specific survival improved from 26% among men with non-small cell lung cancer that was diagnosed in 2001, compared to 35% among those who were diagnosed in 2014. They have shown that these results, they concluded that were because of the early diagnosis of the lung cancer and along with the improved treatment modalities, especially the use of the targeted therapies. This is how management has changed over time in lung cancer. First, we used to treat it with chemotherapy plus radiation. Then, when histological breakdown was there, non-small cell carcinoma, small cell carcinoma, squamous cell carcinoma, large cell, and the adenocarcinoma, targeted therapy came into play. And then came the molecular pathology, EGFR, ALK, ROS1, and the immunotherapy come into play the role. But at present, we treat the carcinoma lung with combination of various therapies. This is the main treatment modalities which are used for the carcinoma lung: surgery, chemotherapy, radiotherapy, and immunotherapy. Non-small cell lung carcinoma, stage 1, stage 2, if patient is fit for surgery, he will undergo the surgery. If it is unfit because of some medical comorbidities, or there are other comorbidities by which surgery is not possible, he will undergo the radiotherapy, definitive radiotherapy. If patient has a stage 3 disease and it is inoperable, patient will undergo definitive CTRT. If disease is borderline, he will be receiving the induction chemotherapy. Fit for surgery, underwent surgery, not fit for surgery, radiotherapy plus minus chemotherapy. If patient is operable, definitive surgery followed by adjuvant RT plus minus chemotherapy. And in stage 4, palliative radiotherapy or palliative chemotherapy, supportive care, hospice care, medication or brachytherapy is indicated. It has been seen that after initial treatment in the early resectable non-small cell lung carcinoma, either with surgery plus minus chemotherapy or radiotherapy, after 5 years, 40 to 50% remain cancer-free, but at the same time, 50 to 60% recur with local or the distant recurrence. This shows the importance of the adjuvant treatment, whether chemotherapy, immunotherapy, or targeted therapy that is very much indicated even in early stage lung carcinoma. These are the CART guidelines on the neoadjuvant and adjuvant chemotherapy depending on disease stage and findings. Stage 1A, we will do observation. Stage 1B, 2A, there is still, this is a gray area. We need proper discussion. A multidisciplinary team needs to discuss whether we need, this patient will be benefited with the neoadjuvant or the adjuvant treatment. Stage 2B, adjuvant chemotherapy recommended. No benefit of neoadjuvant chemotherapy has been shown. Stage 3A, 3B, neoadjuvant chemotherapy or adjuvant chemotherapy, sequential chemotherapy plus radiotherapy only if patient has a N2 disease. This was a meta-analysis. They have compared neoadjuvant versus adjuvant chemotherapy in stage 1B, stage 3, non-small cell lung carcinoma. They have seen that the adjuvant, whether adjuvant or neoadjuvant, both has an equal benefit. There is no difference between the two. This is the timeline how the treatment of non-small cell lung carcinoma from early to late stage targeted and immunotherapy has changed. As we see here in 2006, chemotherapy with bevacizumab for non-squamous cell lung carcinoma started. And now we're in 2020, capmatinib, eculizumab, you can see a significant increase in approval of both targeted as well as immunotherapy in non-small cell lung carcinoma. This is the molecular targets in non-small cell carcinoma. Molecular profiles in adenocarcinoma includes the KRAS mutation, EGFR mutation, ALK fusion, RAS1 fusion, PET fusion, MAP3K1 mutation, and unknown. There are certain unknown mutations also. But there are 7 molecular alterations which are FDA approved for the targeted therapies, which includes the EGFR, ALK, ROS1, BRAF, V600E, NTRK, MET exon 14, and RED. This increases the need for the molecular testing and non-small cell lung carcinoma, and it should be the standard of care in these patients. These are the 2 studies, Flora and the Alex study. They have seen 50% of patients with advanced non-small cell non-small cell lung carcinoma have a driver mutation targetable with the FDA-approved agent or on non-clinical trial. Here they have seen that the osimertinib versus first-generation EGFR has a better overall survival. And in Alex trial, they have seen the progression-free survival with first-generation elicitinib versus crizotinib. They have seen that the elicitinib is a better overall survival and progression-free survival in locally advanced non-small cell carcinoma. So we started with the locally advanced non-small cell carcinoma for the targeted therapy. Then we moved to the early stage non-small cell lung carcinoma. This is a trial, ADURA trial, in which patients with completely resected stage 1B, 2, 3A, EGFRM patients were divided into osimertinib versus placebo. They studied for 3 years the recurrence. What they observed that with introduction of EGFR TK1, disease-free survival is improved from 44% in placebo to 90% in EGFR TK1 arm at 24 months. We can see that we change it from the locally advanced to the early stage for these targeted therapies, and they have dramatically increased the survival in these patients. And these targeted therapies have been included in the NCCN guidelines, like 1B includes the osimertinib, 2A pembrolizumab, 2B atezolizumab, and stage 3A osimertinib. These are the approvals for the immune check inhibitors over time. In 2015, from pembrolizumab to the cemiplimab in 2021. So we have traveled a lot from 2015 to 2021. These are the survival outcomes with the immune checkpoint inhibitors. Historically, non-squamous cell and squamous cell carcinoma with platinum doublet chemotherapy, the overall survival is 18 months. We are talking about the 2002. And then non-squamous cell carcinoma, platinum doublet with the bevacizumab, survival improved to the 12 months. We are talking about the advanced stage non-small cell lung carcinoma. And non-squamous cell carcinoma, platinum doublet with maintenance pemetrexed, 14 months overall survival. Immunotherapy based on histology with any PD-L1 mutations. Here, the platinum in non-squamous cell carcinoma, platinum with pemetrexed with pembrolizumab, we can see the overall survival 22 months. Carboplatin, paclitaxel, bevacizumab with azitalumab, 19 months. Carboplatin with non-paclitaxel with nab-paclitaxel with atezolizumab, 19 months. And in squamous cell carcinoma, carboplatin with paclitaxel or nab-paclitaxel with pembrolizumab, 17 months overall survival. Non-squamous cell and squamous cell carcinoma, eplizumab with nivolumab with 2 cycles of the platinum doublet chemotherapy, overall survival was 16 months. Immunotherapy based on PD-L1 and any histology, we can see here that the PD-L1 greater than 50%, single agent pembrolizumab, overall survival has improved to the 30 months. We can compare here, and we have not subjected the patients to the systemic chemotherapy, so the side effects are low, ease of administration is low. And if we use azitalumab, overall survival is 20 months. And if PD-L1 is greater than only 1%, with pembrolizumab, overall survival is 17 months. It is still better. And eplizumab and nivolumab, it is 17 months. So we can see here that the immunotherapy has drastically improved the overall survival in non-small cell lung carcinoma. This is a checkpoint inhibitor. This was a study in which stage 4 non-small cell carcinoma patients were subjected to pembrolizumab. They have seen a drastic improvement in overall survival in these patients. This was a keynote 024 landmark trial. They have seen improved survival in patients with pembrolizumab compared to chemotherapy in PD-L1. This was another trial, a Pacific trial, in which they have the previous trial, the checkmate keynote trial, that included the patients with stage 4 non-small cell carcinoma. But we moved ahead in Pacific trial to the stage 3 unresectable non-small cell lung carcinoma, in which they have seen that the durvalumab demonstrated 42.9% overall survival at 5 years in comparison to this historical overall survival in unresectable stage 3 non-small cell lung carcinoma at 5 years, only 15 to 20%. And NCCN guidelines have included these drugs in immunotherapies and checkpoint inhibitors in the guidelines. In stage 3B, darolutamab has been included as category 1. In stage 3B, again, the darolutamab has been included as category 1. In stage 3C, darolutamab as category 1. This is another trial in which the atezolizumab showed an improvement survival in disease-free survival as well as overall survival in adjuvant setting. So we have started from the stage 4, then we have gone to the unresectable stage 3, and now to the adjuvant setting. The message is that the landscape management of non-small cell carcinoma is changing very fast. Newer therapies have a huge potential to improve survival, especially when detected in early stages. The overall survival has improved across various subtypes with molecular alterations, and use of checkpoint inhibitors has become common across all stages of non-small cell lung carcinoma. The ease of oral immunotherapy or chemotherapy infusions is an added advantage. Have a pleasant evening. Thank you so much.
Thank you for the amazing talk, ma'am. For the next talk, I would like to invite Dr. Abdul Rashid Loan, sir. Sir is consultant medical oncologist, Florence Hospital, Srinagar. Over to you, sir.
Thank you, Mr. Rishabh. How are you?
I'm fine, sir.
Can you share my slides?
Sure, sir. Tech support, can you please share the slides?
Yeah. And Dr. Shahida has given us a good account on the overview of lung cancer, and it has made my talk much easier because she has explained from the beginning when we started how to treat the patient, how to diagnose, and then go on the various treatments coming to targeted treatment, molecular treatment, and immunotherapies in the metastatic setting, now in the adjuvant setting, and the benefits of that. So my talk will be centered around the EGFR mutant lung cancers. Please share my slides. Yeah. So this is the optimizing treatment in advanced EGFR mutant lung cancers. Next slide, please. An overview of the EGFR mutation positive lung cancer. These are observed in 40% and 20% of patients with non-small cell lung cancer in Asian and non-Asian populations, respectively. We had a study in SKIMS about the adenocarcinoma lung, and we had found it around in 35% of patients that they were having EGFR mutation, mainly exon 19 deletion or exon 21, L858 or point mutations. So the incidence rate of EGFR mutation among Indian patients generally is 20 to 23%, much higher in our populations. And EGFR mutations are located in the tyrosine kinase domain and result in increased kinase activity of the EGFR, thus leading to continued cell proliferation. If you see this diagram, the exon 19 deletion is seen in around 53% of patients, whereas exon 21 is around 26% of patients. Rest goes to exon 18, exon 20. We have drugs for those also now available, but mainly these are the two mutations which we are concerned and which we are talking today. Next slide. So we have first, second, and third generation EGFR TKIs now available. Definitely, these are not equal. The first generation we had erlotinib, geftinib, and second generation we had afatinib, dacometinib, and in the third generation we had osimertinib. The erlotinib, geftinib, the first generation TKI, they cause EGFR inhibition, and it is a reversible binding to wild type and mutant EGFR. And these drugs are inactive on T790M mutations. Usually these patients, when they are EGFR mutant, they gradually develop a mutation, T790M, where erlotinib, geftinib, and even second generation afatinib, dacometinib are not effective. So in this second generation, we have afatinib, dacometinib. They cause blockade of the ERB family. They cause irreversible covalent binding to EGFR, ERB2, and ERB4 to inhibit all ERB family signaling. Broader activity to overcome EGFR TKI resistant mutations. When afatinib came in the market, we were told that this is the drug that penetrates blood-brain barrier and it is effective in brain mets. But ultimately, we have found that it is not that effective. Yes, we have a third generation TKI that is osimertinib, and it is EGFR mutant specific inhibitor, and its activity is irreversible covalent binding to mutant EGFR, specificity for EGFR T790M mutant, and EGFR wild type sparing. So it is active both EGFR mutation, which we have exon 19 deletion or 21 mutation, and also EGFR T790M mutants. We get some patients that sometimes who are having both exons 21 deletion, but simultaneously they are having upfront T790M mutant, where the drug of choice will be osimertinib. And second thing that is important for this osimertinib, it is penetration in the intact blood-brain barrier. Next slide, please. So osimertinib is a new standard of care for first-line therapy in patients with EGFR mutant advanced non-small cell lung cancer. As per FLORA trial, Dr. Shahida had mentioned about it, a randomized double-blind phase 3 study to assess the safety and efficacy of osimertinib versus standard of care EGFR TKIs. That's usually they have done this study with geftinib and erlotinib as first-line treatment in patients with locally advanced or metastatic EGFR mutant non-small cell lung cancer. Next slide, please. So osimertinib is structurally distinct from first and second generation EGFR TKIs. In first, we have gefitinib, erlotinib, EGFR sensitizing mutations, reversible. These are reversible, and targeting is reversible binding to EGFR, ATP binding sites. Ability to cross blood-brain barrier is minimal. Whereas second generation, afatinib, EGFR sensitizing mutation, rare EGFR mutations are true. It is irreversible. Covalent modification of the ATP binding site of EGFR and HER2. Its ability to cross blood-brain barrier is minimal. Initially, it was said that probably it crosses blood-brain barrier very, very well. But that time, there was no head-to-head comparison. But now it is said that it is blood-brain barrier penetration is minimal. Then comes the third generation, osimertinib, EGFR sensitizing mutations, T790 mutant resistant mutations. It works on both. So it is an irreversible mechanism and covalent modification of ATP binding site of EGFR. And its penetration to blood-brain barrier is significant. Next. Osimertinib, a third generation, irreversible CNS active EGFR TKI developed to selectively target both EGFR sensitizing and EGFR T790 M resistant mutations. So here, if you see this cartoon plot, EGFR exon 19 deletion and L858 are, it is effective here. EGFR T790M, it fits there also, but wild type EGFR, it doesn't have any action on that. So it causes inhibition of EGFR mutant exon 19 deletion and exon 21 mutation and inhibition of T790M. It has lower activity against wild type of EGFR. It crosses the intact blood-brain barrier, as we find in clinically also now. Next slide, please. Next. So FLORA study design was patients with locally advanced or metastatic non-small cell lung cancer. Inclusion criteria were more than 18 years, WHO performance 0 to 1, exon 19 deletion, L858 or no prior systemic anti-cancer or EGFR TKI therapy, stable CNS metastasis, they were allowed in the study. And osimertinib was given in the dose of 80 milligrams orally daily. The number of patients was divided into 79 and 277. EGFR TKI standard of care, we had used here geftinib and erlotinib. Geftinib, the standard dose, 250 milligrams daily, and erlotinib as 150 milligrams. The assessment was done 6 weeks until objective progressive disease, every 6 weeks in both the groups. And crossover was allowed in these patients where patients with confirmed progressive disease on standard of care and T790M mutation, they were allowed to cross over to the other side. So primary endpoints were progression-free survival based on investigator assessment according to RECIST 1. And secondary endpoints were objective response rate, duration of response, disease control rate, depth of response, and overall survival. Next slide, please. Next, Rishabh. So here, if you see this Kaplan-Meier curves, these are widely separated. Median progression-free survival in the group who received osimertinib upfront, it was 18.9 months versus 10.2 months in the standard of care, that is geftinib or erlotinib. And progression-free survival is a direct measure of the drug's benefit. FLORA was powered for progression-free survival. Next slide, please. So the efficacy of osimertinib across various clinical subgroups like age, sex, race, smoking history, CNS metastasis, performance status, EGFR mutation at randomization, EGFR mutation by circulating DNA, centrally confirmed EGFR mutation. So if you see all the subgroups, it favors osimertinib. Next. The overall survival final analysis was median overall survival with the osimertinib was 38.6 months as compared to comparator. EGFR TKI is 31.8 months. Definitely, there were many patients who had crossed over to the osimertinib after developing T790M mutation. So median overall survival was more than 3 years. Osimertinib patients were more likely to be alive at 2 and 3 years landmark. First time an EGFR TKI is translated progression-free survival to an overall survival benefit. Next. 28% of patients were still receiving osimertinib at 3 years compared to 9% of patients who were receiving the standard of care. So 28% were still receiving osimertinib, which was 3 times more than patients in the comparator arm. And 22% versus 5% of patients still on treatment at the data cutoff was there. Next slide. The time to first subsequent treatment when the treatment failed in osimertinib, it was median 25.5 months, while as in comparator EGFR TKI like gefitinib or erlotinib, it was 13.7%, 7 months. Next slide. So efficacy of osimertinib across subclinical groups, if you see progression-free survival, it favors osimertinib across all groups, age, sex, smoking history, CNS mets, mutation at randomization. And it again in the overall survival, if you see it again favors the osimertinib group. Next slide. So osimertinib progression-free survival benefit was clearly maintained consistently across all subgroups, demonstrating it a superior benefit across all populations, including by race and across the different mutation types, which is important as we discuss overall survival subgroups. All overall survival subgroups showed a positive benefit in favor of osimertinib, although magnitude of benefit varies. This is consistent with progression-free survival data in which all subgroups favored osimertinib. Next. The synopsis of why do we think it is important that patients receive osimertinib in the first line. Next. Approximately 30% of all patients are eligible for osimertinib as second-line treatment for T790M mutation positive non-small cell lung cancer following progression on a or second generation EGFR TKI. Out of 10 EGFR mutant patients who start on first generation EGFR TKI, only 3 will be eligible to receive second line osimertinib. So around 7 patients in 10 will miss the benefit of osimertinib in second line. If you use, in the first line, we use standard of care, the first or second generation TKIs. But if they will be missing the benefit what they could get by using upfront osimertinib. Approximately 50% of patients who are alive and who are able to get an accurate test result will test T790 mutant positive. And some patients do not even get that far because only 60 to 79% can receive an accurate T790M mutant test result. One, not eligible for tissue biopsy, or they are reluctant for going for tissue biopsy again, and some insufficient tissue from biopsy or an invalid test result. We don't know how the test was done. And then the false negative on plasma tests. We miss many these T790M mutations on the plasma test. So only 73 to 77% of EGFR mutant patients receive any second-line therapy. They either die during first line or receive only palliative care upon progression. So that's why upfront, if we give osimertinib, it will definitely give them much more benefit. Next slide, please. So EGFR mutation positive non-small, only about 1/3 of standard of care TKI patients will receive osimertinib. Like these 10 patients, if we take, who are started on gefitinib, erlotinib, or afatinib, among them die during first line, around 20% die during first line of treatment only, or receive only palliative care upon progression. No T790M mutation test being done. So 73 to 77% of EGFR mutations receive second-line therapy. Now, among these 8 patients, if we see 80% of patients, 60 to 76% can receive a valid T790M test result, but not eligible for tissue biopsy. Again, another 20% have insufficient tissue from biopsy, or an invalid test result, or get a false negative on plasma test. So we are not able to give them osimertinib benefit, which they could have got. So of that, these 50% remaining with a valid test results are T790M mutant. So only 30% of them will be eligible for second-line osimertinib. Next slide. So only 60 to 79% of patients can receive an accurate T790M mutation test result. Not all patients are able to receive a valid T790M test result upon rib biopsy. Insufficient tissue, not properly done, or the test not done by a reference lab. And plasma testing may yield a false negative result. So these are the summary of rib biopsy results. This is one of the result in the 2017. 79.2% of patients screening for the AURA3 trial had a valid COBAS EGFR mutation test result. So there were many missing. So in 2014, the biopsy was not possible in 19.5% of patients and provided no or too few tumor cells in 25.6% of cases. So again, missing here. In 2012, approximately 60% of biopsy specimens were suitable for molecular analysis. So again, 40% lesser. And 2011, approximately 69% of patients who consented to biopsy were tested for T790. So we were again missing here. Next slide, please. Next, Mr. Shah. So crossover rates and subsequent second-line therapies for the FLORA experimental arm. First-line osimertinib, still on treatment were 22% and 78% discontinued. No subsequent therapy was given, 31% did not receive and could not receive a second-line treatment. But another 48% received second-line therapy. So they were, sorry. Next slide, please. So the comparator arm was reflective of clinical practice, allowing patients with disease progression to cross over and receive osimertinib. Here, first line EGFR was TKI were given. Some patients, 5% of them remained on treatment. Then 65% received second line therapy in the form of some other EGFR TKI and 47% osimertinib. So crossover was this represent 31% of all patients in the EGFR TKI receiving second line osimertinib. Next slide. So approximately 1/3 of patients do not receive a second-line therapy in phase 3 clinical trials. These are various trials. If you see overall survival, gefitinib 21 months, gefitinib 19 months post-TKI treatment, and 75%. Then erlotinib 19.3 months. Osimertinib, it has gone to 38.6 months. Next slide, in FLORA trial. In a real-world study of patients with EGFR mutant non-small cell lung cancer, the risk of not receiving second-line therapy is high. This was a retrospective study of 140 patients with EGFR mutant non-small cell lung cancer in Germany to identify treatment patterns. So 130 patients, 140 were treated with first-line EGFR TKI, 10 patients received first-line chemotherapy. So 112 patients were candidates for second-line therapy. 34 of the 112, 30% of these patients did not receive second-line therapy. The reasons for not receiving second-line therapy: patient refusal, poor performance status, fast progression, and death. This has happened and frequently due to CNS disease. This has happened to in a country where the things are available easily, and patients have insurance and they can go for any sort of tests and any sort of treatment. So if we take in our country, it will be much higher like that, the patients missing the treatment. Across all lines of therapy, only 29% were treated with third generation TKI after accessibility. Next slide. In our area also, I remember patients where we used to get biopsy, even rebiopsy on progression on the first generation TKIs. And sometimes you had nothing else to offer. And this biopsy came negative. Even for the EGFR mutation, probably the tissue was less, which was there. At least that should have come positive. Probably less tissue and false technique of doing the test. So this is a problem here also. So real-world data across multiple countries confirm that in clinical practice, 1/3 or fewer patients receive second-line osimertinib. Next slide. So head-to-head clinical trials of EGFR TKIs are consistent with real-world data. Not all patients can receive second-line osimertinib. So you see in this chart also, second-line treatments in FLORA as well as Archer, these second-line treatments, all the patients did not receive this second-line osimertinib. Next slide. Next, please. So if we give treatment sequencing, please go to previous slide. If we sequence the treatment in this way, that we use first-line osimertinib versus second-line osimertinib. Osimertinib first line, if we use our this 18.9 months, while as then if they progress, we go to the chemotherapy. But if we use standard of care TKIs in the first line, the survival is 10.2 months only. But if they develop a T790M mutation, which we miss in many don't do it, many die before that. So if we get a T790M mutation, their survival will be further. If we use osimertinib, it will go to 10.1 months. But if we combine these two, it will be much higher than the osimertinib as first line. But the of our patients do not receive second line. They don't. Some of them we have already lost, or some they don't go for any second line testing, or faulty techniques of doing the test. We get a negative result, or we do a liquid biopsy, we get a false negative result. So we are not able to give them osimertinib. That's why if we take this standard of care TKI is 10.2 months survival compared to 18.9 months, around 19 months. So we are missing around 9 months of this overall survival benefit in these patients who miss their osimertinib. Next. Next slide, please, Rishabh. So key messages: osimertinib is the only EGFR TKI which has demonstrated a clinically and statistically significant improvement in overall survival. The FLORA trial was the first to demonstrate how an EGFR TKI has translated progression-free survival into an overall survival benefit. Osimertinib is well tolerated at its recommended dose of 80 milligrams. I am having many patients on osimertinib. I don't think any of them, except a little fatigue, they don't develop much of the side effects, which I have seen with erlotinib, rash, which go to, sometimes we have to discontinue the treatment and the areas. But in osimertinib, luckily, maybe it is me only that I have seen less of the side effects with the osimertinib. The tolerance is much better. Osimertinib improved overall survival versus first generation EGFR TKIs in untreated EGFR mutant non-small cell lung cancer and T790 non-small cell lung cancer that has progressed on first line EGFR TKI. Acute events leading to dose reductions are frequent in the second generation EGFR afatinib and dacomitinib. There we usually don't go beyond 30 milligrams because 40 they usually don't 40 we don't go beyond 40. They don't tolerate 60. Osimertinib is the only EGFR TKI to report statistically significant intracranial efficacy. So if we don't have this here, otherwise you can see the patients who had brain mets, it worked well, and when we did subsequent MRIs, they showed the regression in the brain mets. And sequencing cannot be considered the best strategy because almost 70% of patients are not eligible to receive osimertinib in the second line, which they would have benefited if we had used it in the first line. Next slide. So NCCN guidelines, again, they recommend preferred line of treatment in the EGFR mutation prior to first-line systemic therapies, osimertinib, category 1. You have other treatments also, others also category 1, but this is the preferred one. Next slide. Thank you very much. Thank you.
Thank you, sir, for such an informative talk. It was great to hear you. For the next talk, I would like to invite Dr. J.B. Sharma, sir. Sir is Senior Consultant, Head Department of Medical Oncology, Action Cancer Hospital, Delhi. Over to you, sir.
Dr. Sharma, seeing you after a long time.
Yeah, Dr. Long, how are you?
I'm fine. How are you? Why don't you plan to come to Gulmarg someday?
Yes, definitely. We had one Biocon meeting,
Right.
Biocon meeting and Trastuzumab meeting. Then we met there and yes, we can plan there also, physical meeting also.
Yes, sure. Okay.
I'm not able to play my video, means my presentation. So
Tech support, can you please share slides, right?
okay, I'll now try to share my slides. Okay.
Sure, sir. Sure, sir.
Mm. Is it visible?
Yes, sir, it is visible. Sir, please make it full screen. Yes, sir, it is visible.
Okay. So, good evening, everyone, and thank you, AstraZeneca, for inviting me for this very important discussion. And so, my topic is decoding treatment options for EGFR mutated non-small cell lung cancer. So these are the worldwide data for all cancers, and these already have been discussed, but I just want to emphasize that lung cancer, the number of deaths is second highest after the other cancer. So you can take it as that only the first cancer or that most number of mortalities are associated with lung cancer. And if you see the number of new cases is second highest after breast cancer. Lung cancer incidence is second highest in both sexes. So second most commonly diagnosed cancer, 11.4% of the total cases, and leading cause of cancer death, 18% of total cancer death. So the parameters which determine the choice of first-line treatment in advanced EGFR-mutated non-small cell lung cancer includes progression-free survival, overall survival, overall response rates, presence of brain metastasis, safety and toxicity, quality of life, and patients receiving subsequent therapy upon progression. So these are the parameters which determine that what should be your first choice of treatment options. So if you see the FLORA trial, that osimertinib provided unprecedented improvement in progression-free survival. These are the cross-trial comparison and cross-agent comparison, that molecular comparisons. But we should take that PFS in all the trials. That if you see the IPAR, gefitinib, optimal, erlotinib, Lux Lung 7, afatinib, dacomitinib, and osimertinib. So these includes first generation. So first generation PFS has been around 9 to 10 months. Second generation TKIs have 11 to 14 months. And third generation, osimertinib is a third generation, and it has a PFS of approximately median PFS of 18.9 months. So this is the highest among all these three generations. And you can see here, if you see the efficacy, progression-free survival based on different clinical trials, and there is caution already has been written that cross-trial comparisons without head-to-head comparative studies are, you have to take with it. But you can see the differences. So Lux Lung 7, afatinib versus gefitinib. Stable brain metastases were included, which was around 16%. And here, that progression-free survival was almost 11 or 10.9 for gefitinib, afatinib 11, and hazard ratio 0.73. While comparing with dacomitinib versus gefitinib, the all brain mets were excluded in this trial. There were no brain metastases were taken, and you can see gefitinib 9.2, dacomitinib 14.7. Up to 6 months, the curves did not separate, so the difference was only seen after the 6 months, and hazard ratio is 0.59. FLORA trial, it included stable brain metastasis 19%, and you can see in the beginning only, with first 2 months, the curve started separating, and that erlotinib or gefitinib, that PFS was 10.2, and you compare with 18.9 median PFS, and the hazard ratio is 0.46. So early separation of PFS, curves is shown by osimertinib only. So afatinib versus gefitinib, 12 months separation curve. After dacomitinib 6 months, here only 1 to 2 months only. Overall response rate, if you see different trials, overall response rate of afatinib was overall response rate was 70, and disease control rate was 91 versus 87 in gefitinib. Overall response rate 70% versus 56. Median duration of response 10 versus 8.4. And patients with more than 50% tumor shrinkage 44 or 36. In dacomitinib, complete response has been shown as 5%, in gefitinib 2%, partial 70%, stable 13%, 12%, progressive disease 5 to 7%, and median duration of response is around 14.8 versus 8.3. Coming to osimertinib, overall response rate is 80% versus 76. Odds ratio 1.27. Complete response 7 versus 4. and partial response 77% versus 74%, stable disease 17, progression 1% and 5% in other TKIs, and the duration of response is 17.2 versus 8.5, 12 months 64 versus 37, and osimertinib has shown highest overall response rate and median duration of response. So these are the findings of and comparison with different trials. Coming to overall survival, when final analysis of FLORA trial was done, then you can see here 1 year, 2 year, and 3 year differences. So median overall survival was more than 3 years. Osimertinib's patients were more likely to be alive at second and third year landmarks. You can see here second year 74% versus 59%, third year 54 versus 44%. So 10% of the difference you can see. First time an EGFR TKI has translated progression-free survival to a significant overall survival benefit. So 3-year overall survival is 54% versus 44%. And if you see here, median OS is total, if coming total, 38.6 versus comparator 31.8. Hazard ratio for this is 0.79. Lux Lung 7 and Archer 1050. You can see here also afatinib versus gefitinib, hazard ratio 0.86 and 27.9 versus 24.5 months. So afatinib failed to improve overall survival versus gefitinib in Lux Lung 7. So there was no improvement in overall survival. In Archer 1050 dacomitinib versus gefitinib, here also the curve shows there is a difference, but it is statistically not significant. So in Archer 1050, hierarchical gatekeeping procedure was used for hypothesis testing, where PFS is more than overall response rate, which is more than overall survival. So ORR was not statistically significant, and hence formal statistical hypothesis testing for overall survival was not conducted. So this is all discussed in this article where it was published in Current Oncology. And this is a Canadian consensus, a new systemic treatment algorithm for advanced EGFR mutated non-small cell lung cancer, where they have found that phase 3 Archer 1050 trial excluded patients with brain metastasis, although if reported a numeric improvement in OS of 34.1 months for dacomitinib, 29.5 months to 37 months, this is the range, compared with 26.8 months for gefitinib. The trial had a hierarchical stratified statistical design, and given that it did not meet significance in overall response rate, a p-value could not be given to OS. So here we should not take that there is improvement in the overall survival because they excluded brain metastasis patients. So coming back to osimertinib, 28% of the patients were still receiving osimertinib at 3 years of treatment. So you can see here, at 12 months, 70% were receiving, while gefitinib 47%, 24 months 42, 16%, at 3 months 28% versus 9%. So 28% of the patients were still receiving osimertinib at 3 years, which was 3 times more than the patients in the comparator arm, which was 9%, and 22% versus 5% of the patients still on treatment at data cutoff value. So even after data cutoff has been done, and still the patient is 22% of the patients are still ongoing on treatment with osimertinib. So osimertinib demonstrated a superior systemic progression-free survival benefit regardless of CNS disease status at steady entry versus EGFR TKI comparator. So you can see here in this first with non-treated or CNS metastasis, standard of care median PFS with osimertinib is 15.2 versus 9.6 and hazard ratio is 0.47. You can see the curve separated in the beginning only. So the patient who were treated or with non-metastasis, CNS metastasis, has a median progression-free survival of almost double as compared to EGFR TKI. First generation notes. Without non or treated CNS metastasis, osimertinib 19.1, standard of care 10.9. Hazard ratios here also 0.49. So median PFS here was higher as compared to brain metastasis because it also prevented the brain metastasis to emerge. Okay, so without non-metastasis or treated CNS metastasis without, so it prevented the development of brain metastasis, hence increased the progression-free survival. So CNS progression events occurred in 6% versus 15% of the patient receiving osimertinib versus standard of care in all patients. Intracranial progression-free survival, CNS full analysis set, you can see here, the median CNS PFS was here osimertinib not reported versus standard of care 13.9 and hazard ratio for 0.48. So CNS PFS was statistically significant with osimertinib versus comparator. Significant CNS response to first-line osimertinib patient with EGFR mutated advanced non-small cells and CNS metastasis. So you can see here that there are all the generations, afatinib, dacopatinib second generation and osimertinib third generation. Patient population, afatinib asymptomatic baseline brain metastasis. Baseline brain metastasis were excluded in dacopatinib, and here there were symptomatic or asymptomatic baseline were, and patients who were treated, they were also included. So median PFS by here you can see afatinib in CNS median PFS 8.2 versus 5.2, and in other trial 7.2 versus 7.4. In dacopatinib not available because brain metastases were not included. Osimertinib 15.2 versus 9.6, and in baseline asymptomatic CNS metastases were not reported. Median PFS has not been reported versus 13.9. Coming to the safety and adverse events of grade 3, 4, or 5, you can see here grade 3 or 5 adverse events with dacopatinib were reported in 63% of the patients in Archer 1050 study. Grade 3 or more than grade 3 adverse events with afatinib were reported in 31% of the patients in Lux Lung 7 trial. Grade 3 or more than grade 3 adverse events with osimertinib were reported in 18% of the patients in Flora trial. All-cause grade 3 or were occurring more than 1% of the patients receiving osimertinib in Flora trial are listed in here. That there is decrease in appetite, diarrhea was slightly or almost equivalent, prolonged QT interval was slightly higher, fatigue same, rashes same. Rashes were even less as compared to the other first generation TKI. So coming to skin reactions, afatinib has 9%, dacopatinib has 14%, osimertinib less than 1%. Coming to paronychia, Paronychia 2% in afatinib, 7% in dacometinib, less than 1% in osimertinib. Diarrhea incidents were highest in afatinib and dacometinib 8% and lowest at the rate of 2% in osimertinib. Stomatitis 4% in afatinib, 4% in dacometinib, and less than 1% in fluoride, osimertinib. So dose reductions in EGFR TKIs. So the second generation EGFR TKI afatinib and dacometinib have been shown to frequently cause adverse events that require a dose reduction. So coming to Lux Lung 7, adverse events leading to dose reductions were more frequent in patients receiving afatinib compared with gefitinib, and that this is 41.9% versus 1.9% respectively. So almost approximately 50% of the patient required dose reduction for afatinib. Coming to Archer 1050, there were more dose reductions in patients in the commutative group compared with the gefitinib group. And it's more than 50% of the patient, more than two-thirds of the patient received dose reduction versus only 8% in gefitinib arm. Coming to FLORA trial, the frequency of dose reduction was similar between osimertinib and standard of the care arm. So it is approximately 5% and 4% respectively. So less number of the patient, only marginal number of 5% of the patient had dose reduction in FLORA trial, while it's more than two-thirds in dacometinib and more approximately 50% in afatinib arm, which required dose reduction. Coming to the quality of life, the global quality of life was maintained with the dacometinib group and was significantly improved, but not considered as a clinically meaningful improvement in the gefitinib group on a 100-point scale. So there are various parameters which has been taken, like cough, dyspnea, pain in chest, pain in the shoulder or arm, pain in the other parts, fatigue, diarrhea, stomatitis, and global quality of life. These were the parameters which were taken. And coming to the osimertinib, the global quality of life was improved from baseline in both osimertinib and EGFR TKI comparator groups with no clinically relevant differences between groups. So here the parameters which were taken like cough, dyspnea, pain in chest, appetite, and fatigue. So here it was improved in both the arms. Coming to that second line treatment option, so 1/3 of the all EGFR mutated patients treated with first or second generation EGFR TKI are able to receive second line osimertinib. So out of 10 patients, EGFR mutated patients who start with gefitinib, erlotinib, afatinib, only 3 will be eligible for second line osimertinib. How? Consider 7 out of 10 patients who start on first generation. For example, we start 10 patients with EGFR first or second generation. Then 73 to 77% of the EGFR mutated patients receive second line therapy, because two patients out of these, 2 patients died during first line or receive only palliative care upon progression on T790M test, because no T790 test is there. Here 60 to 70% can receive a valid T790M test result, and again 2 are not eligible because of tissue biopsy. They are not eligible for tissue biopsy, or they have insufficient tissue biopsy or invalid test result, or get a false negative or plasma test. So approximately 50% of those with the valid test results are T790M positive, and 3 patients again are negative. So only 3% patient will get second line osimertinib if you give osimertinib as a second line. So 7 out of 10 patients are will not be eligible for second line osimertinib. So not possible to predict who will develop T790M resistance. Access to second line therapy, if you compare in different trials, IPAS, IFUM, NEGM, UTAC, Optimal, all type of Lux Lung 7 or 3. Approximately 1/3 of the patients will not have access to second line treatment. This may be because their condition deteriorates. This may be because they are not able to take second line treatment, or we don't have any T790M mutation. So in second line, it's indicated only when there is T790M mutation, then and then. So real world evidence after afatinib of T790M mutation development. In a Japanese study, 43% of the patient acquired T790M mutation after first line afatinib. In Taiwanese, 48% of the patients who were rebiopsied after afatinib failure had acquired T790M mutation. And in another Taiwanese study, 28 afatinib treated patients, it was diagnosed in 32% of the patients. So T790M mutation is generally found in 32 to 48% of the patients. Less than 50% of the patients put on afatinib acquired T790M mutation. So how do we sequence EGFR TKI so that we can get the maximum benefit? Starting with prior generation EGFR TKI and then treating those that developed EGFR TK T790M mutation with osimertinib. This is not optimal clinical care because we are not smart enough to figure out who will get EGFR T790 mutation, because only 50% of the patient usually get that mutation, less than 50%. Not everyone will be well enough to receive additional treatment. 30% of the patient don't receive any subsequent therapy because of their ill health or progressive disease or poor performance status. Tissue or liquid biopsy is not always successful, so we are not able to sometimes find out exact T790M mutation status. Hence, patient is denied since we don't know second line EGFR mutation status. Hence, we cannot blindly start osimertinib. Osimertinib associated with a significant survival benefit as a first line. This has been already discussed and shown in the FLORA trial that there is significant overall survival benefit. Other factors are uncontrollable factors in sequences. For example, toxicity to drug, occurrence of T790 mutation, sites of progression, concurrent morbidity, and patient choice. Real-world studies with first-line osimertinib. So these are that various studies which have been done. So flower study, first-line osimertinib in real-world and international, inter-regional prospective study. This is a real-world prospective observational study done in Italy at 9 centers, total number of patients 126 from June 18 to September 20. First line metastatic advanced stage 3B EGFR mutated patient. All patients were white, median age 68, adenocarcinoma and squamous cell carcinoma. PS approximately 12 or more than 2 was 2.7. Brain mets at baseline 30%. Comorbid index was more than 6%. Deletion 19, 63%. Exon 21, L8, 58R mutation 55%, rare 3, complex 4. Outcome CR was seen in 0 patient, partial response 73%, stable disease 23%, and overall response rate is 96%, progressive disease 4%. Time to treatment discontinuation, time to TTD is 25 months, 5.5 months. Median time to treatment discontinue patient with or without symptoms at diagnosis 18.8 months. Less than 3 or at least 4 metastatic sites, median time to tumor treatment discontinuation is 21.4 months. Progression-free survival, median PFS is 18.9 months, which is almost same as of that LoRa trial. Median PFS in patients with or without brain mets at diagnosis 13.3%, 3 months. Median PFS in patients with or without symptoms at diagnosis 15.5 months. It's all similar to the LoRa trial. These are the real world patient data where PFS more than 2 also has been included, and brain mets were seen in 30% of the patients. So diagnostic pathway safety data and conclusion, if you see here, the median in patients without recurrent disease, median time from biopsy to pathological report 7 days, from pathologic report to EGFR mutation 8 days, EGFR mutation status report to osimertinib start 17 days. Most common adverse event, diarrhea, skin rash, paronychia. Most common severe adverse event, venous thromboembolism, 7.9%. This has not been seen. This is no difference in cases of VT was reported according to age, PS, comorbidity, and tumor load. And no difference in survival outcome was observed according to the age, comorbidity, and type of EGFR mutation. So these data suggest that osimertinib confirmed effectiveness and safety in the real world. And although thromboembolism was more frequent than previously reported, you have to be alert enough when you see any signs and symptoms of venous thromboembolism. OsiFact, this is a study from Japan, and osimertinib first-line treatment of advanced EGFR mutated in real-world setting. Here also 49% has deletion 19 and 45% has exon 21 mutation, uncommon 5%, adenocarcinoma 98. Median age here was higher as compared to that Italy population. Number of patients were also higher, 538. And brain metastasis similar, 32%. Here PS more than 2 or equal to 216.2%. Outcome oral response rate 76% and disease control rate 94%. It's all similar as compared to the Flora and Italian study. Median PFS 20.5 months is higher as compared to the Flora. Median time to treatment failure 19.1 months. And median PFS you can see here. This is again median PFS based on PDL1 positivity, TPS score 1 to 49, less than 1%, 20%, and 20 months. So these are the various subgroup analysis. So median time from the start of treatment to the onset of adverse events was 56 days, approximately 2 months. And the pneumonitis all grade was seen in 12% of the patient within 56 days. Grade 3 or less than 3, 4.5%, but grade 4 was in 0.7%. Grade less than 3 hematotoxicity 4%, grade less than 3 non-hematotoxicity 11%. Reasons for treatment discontinuation. These are the various regions where patient has disease progression. Most of the patient 44% progressive disease and 25.6% developed pneumonitis. So pneumonitis of all grade was higher as compared to Flora trial. So what is difference? You can see here in Japanese population, pneumonitis is higher. Italian population, there is venous thromboembolism is higher. Indian population, we don't see much of the pneumonitis. We don't see much of that venous thromboembolisms also. So genetically different populations have different side effects, and Indian population generally tolerate very well. So I have not seen any patient with pneumonitis on osimertinib or thromboembolism. PFS after first line osimertinib treatment in real world practice was favorable. The discontinuation rate due to adverse event, especially pneumonitis, requires further investigation. So Mykonos study, this is from the USA, Japan, Germany, and China. Here also PFS more than 2%, 49, 97%. Adenocarcinoma brain mets 33%, and exon 19 deletion 51%, exon 21 33%, and you can see here also median follow-up time 9.6 months and median real world next time to next treatment is 7.9 months, and treatment discontinuation was 17.2 months. The interim real world treatment discontinuation and treatment to next treatment result support the effectiveness of osimertinib in this real world population. Longer term outcomes will be evaluated in final analysis. So what does the guideline says? EGFR exon 19 or L858R, EGFR mutation discovered, osimertinib is the first preferred line of treatment. Osimertinib maintains a strong recommendation for first-line use. Patient with these mutation, osimertinib monotherapy, gefitinib with double chemotherapy, dacotinib monotherapy. These are the other options, but the best option is strong evidence is against osimertinib monotherapy. So coming to that summary, osimertinib is the only EGFR TKI which has demonstrated a clinically and statistically significant improvement to overall survival. The median OS benefit of greater than 3 years sets a new benchmark for osimertinib and provides a window of opportunity for the management of patients with stage 4 non-small cell lung cancer with sensitizing mutation, reaffirming its importance as the first line therapy. FLORA is the first time as an EGFR TKI has translated PFS into OS benefit. Nearly 30% of the patients remained on osimertinib even after at 3 years. Osimertinib is the only drug which can be given in patients with brain metastasis and T790M mutations. Osimertinib is the safest and least toxic drug among all the available options. Sequencing can't be considered the best strategy as almost 70% patients are not eligible to receive osimertinib in second line. So these data confirm osimertinib as the first line standard of care in metastatic EGFR mutated non-small cell lung cancer. These are the prescribing guidelines. And thank you very much for your patient listening. Thank you, everyone.
Thank you, sir, for the amazing talk. With this, we come to an end to our meeting today. And I would like to thank all the speakers and the pharma team, our academic partners, for making this meeting successful. And with this, we close our today's meeting. If anyone has any question, answers to do, anyone?
Mr. Rishabh, is there any chance of getting the cost of osimertinib a bit lower? I know in schemes we are getting it for 1,06,000.
Sir, actually, I'm not a doctor, so I don't know the answer.
Okay, sir. Regarding that cost, sir.
Yes.
Sir, cost is current cost is 1.20 for the 30 tablets with the assistance program.
Right.
For a month. And we also launching a new PAP program for our patients. So in that, if patients is continue in the 9 months taking medicine, next 3 months they will get the free medicine.
Right.
On the first year, and the second year is the PAP become the 6+6. patient will purchase 6 months and the next 6 months will got free.
Right. Thank you very much.
Fine, sir. Thank you.
Thank you everyone for joining. Good night, everyone.
Good
Tech
night.
support, please close the meeting.
Good night.
Thank you, team. Good night, sir.
Good night.